All right, good morning, everyone. We're going to get started. Thank you, everyone, for joining us today, here in person and online. I want to welcome two fantastic speakers who are joining us today. Dr. Jessica Briggs is an assistant professor in our division here, and Dr. Grace Hazer is an infectious disease fellow in our program here at UCSF. Dr. Briggs and Dr. Hazer have been really pivotal in our clinic in terms of Hep C detection and cure and thinking through like Hep B vaccination and reactivation in our patients on long acting. And so we're really excited to have them talk about real cases from our clinic here at Ward 86. Their talk is titled Lowering Barriers to Cure, Updates in Viral Hepatitis Management for People Living with HIV and Hep C Point of Care Testing. So welcome both of them to Grand Rounds.
Okay, neither of us has any disclosures. And just a quick outline, we're going to talk about hepatitis C first, and I'm going to present on hepatitis C for the primary care physician, try to convince you that you can treat anyone, almost anyone, for hepatitis C on your own in the primary care clinic. And then Grace is going to talk about some really exciting updates in point of care testing and rapid test and treat, and then give some interesting cases on hepatitis B. So we have very, very highly effective cure for everyone with hepatitis C that just simply isn't reaching enough patients. So this is data from the CDC showing that only 1 in 3 people are cured overall, but risk factors for not being cured are being young and without insurance. And so we really have to get to that last mile of patients who we have difficulty either identifying that they have the infection or getting them all the way through the treatment pathway to cure. I will say that, at Ward 86 in particular, we do an amazing job of screening and treating people, and we outperform the nation. And Grace is going to get into that a bit with some data to show you. But even in our clinic, right, there is that last mile of patients that we need to cure. And I think that's something that should be on your mind when Grace is presenting this rapid test and treat algorithm with the point of care testing that's recently come out. So this is just basic screening. All adults should be screened at least once. I think our text fonts were changed. Okay. Unfortunately, some of these slides may not look like they should because it looks like our text fonts were changed. But all adults should be screened at least once. And every time a person is pregnant, they should be screened. But for our patient population, what's most important to remember is that if you have ongoing risk factors for hepatitis C infection, such as men who have sex with men, if you're on PrEP or using injection drugs, then you should really be screened every 6 to 12 months. And that's really up to the clinician in terms of how often you screen. But I do think yearly is probably where most of us fall. And remember, of course, that anyone who's been infected in the past and successfully treated will need a viral load for screening in the future, not the hepatitis C antibody test. Oof, yeah, everything's a little messed up. Okay, so just a reminder that we have 2 treatments for hepatitis C that work for all genotypes, so genotypes 1 through 6. That's GLP-1, which is Mavyret, which is a hepatitis C PI and NS5A inhibitor. And Mavyret is 3 pills once daily for 8 weeks. Patients love the short duration of this treatment. The only problem is that the pill burden is a little bit higher. So if the patient prefers fewer pills per day, your best option is Epclusa, which is or Sofel, which is a hepatitis C polymerase and NS5A inhibitor. Also works for every genotype, and it's just 1 pill daily for 12 weeks. Patients tolerate these medications really, really well. In general, you're just not going to have many complaints. And if you do have these complaints of headache, nausea, fatigue, toward the beginning of treatment, they tend to improve during treatment. So there's this, in 2023, the IDSA and ASLD published these simplified treatment guidelines. And previously, persons living with HIV were in a separate category, not eligible for the simplified treatment guidelines, but now they are, based on a study I'll present in a moment. So there are very few people who cannot be treated under the simplified guidelines. The most important ones, I would say, are people who are hepatitis B surface antigen positive, people who have decompensated cirrhosis. Those people should be treated by a specialist, and current pregnancy. known or suspected hepatocellular carcinoma is also a contraindication from the simplified treatment algorithm, because those patients should be treated in conjunction with the liver specialist. So for any patient who, any genotype who has no cirrhosis or compensated cirrhosis defined as Child-Pugh class A, they can be treated for using the simplified treatment algorithm. And in here it says, quote, have not previously received hepatitis C treatment. I think that's a little confusing. If someone has previously received hepatitis C treatment and been cured, then then their reinfection is just treated along the same exact simplified treated guidelines. But if they have failed treatment, that's, I think, what this guideline should say, they are not eligible for the simplified treatment pathway. So what do you need in terms of pre-treatment assessment for simplified treatment? You can calculate a FIB-4 score to assess for cirrhosis. So that is like the only test you really need to determine whether or not you're worried about fibrosis or cirrhosis in a patient. And then if you do suspect advanced fibrosis or cirrhosis, you should order an ultrasound for screening for hepatocellular carcinoma, but you don't necessarily need to get that ultrasound before you start treatment. For the rest of the labs, having updated CBC hepatic function panel and GFR in the last 6 months is useful. It's really important to do a med rec and assess for drug-drug interactions. We'll talk about some of those today. And then, of course, you'll want to have a quantitative hepatitis C viral load sometime in the past 6 months to a year. And you need a hepatitis B surface antigen, because patients with hepatitis C and hepatitis B co-infection are treated a bit differently. Obtain pregnancy testing if appropriate, and then, of course, counsel on adherence and provide language navigation services. So this is something that's really important in our patient population. If your patient is at Ward 86, we do have navigation services through Shanti. So you can just reach out to me or any of our pharmacists, and we can link your patient up with Shanti for navigation services, and they can also get financial incentives through that program, which really helps people finish their treatment. If you have questions about genotyping, I will get to that in a bit. So case number 1, here's a 45-year-old man who has a history of IV drug use, has HIV on Simtuza. And at his last visit, you get a hepatitis C antibody reflexes with the viral load, and it's positive. And his FIB-4 score is 1.2, which is not consistent with advanced fibrosis or cirrhosis. His genotype is pending, and he reports he's never been treated for hepatitis C. And he wants to get started on treatment, but he's worried about how many times he's going to have to come in and be present at the clinic. So what hepatitis C treatment do you recommend, and how much monitoring is required? I'll just wait a couple seconds here. The first options are all Epclusa, which is Sofvel, for different durations, 8 or 12 weeks. And then the difference between B and C is optional monitoring of hepatitis C viral load at 4 weeks or required hepatitis C viral load at 4 weeks. And then D and E are for Mavyret or Glipib, which is 8 weeks of therapy with either optional monitoring of hepatitis C viral load at 4 weeks or required at 4 weeks for E. F is wait for the genotype. All right, I can't tell how many people have, I'll just go forward. All right, we have votes for B and D. So either Epclusa for 12 weeks with optional monitoring of hepatitis viral load at 4 weeks, or Mavyret for 8 weeks. So you got the two choices are Epclusa for 12 or Mavyret for 8, right? But the trick to this question is knowing your drug-drug interactions. So in a patient on Simtuza, which has a protease inhibitor in your HIV medication, darunavir, you cannot co-administer that with Mavyret or Glipib. So the right answer here is actually B, Epclusa for 12 weeks with optional monitoring of hepatitis C viral load at 4 weeks, and SVR check 12 weeks post-treatment. So yes, the important things to note here are that you do not need a viral load at any point during treatment. It's not required. If you are able to get one at 4 weeks, it's very predictive of whether or not you will be able to achieve SVR, because if the viral load has decreased by 2 logs or is negative, then you know that you're doing, like the patient is adherent and taking the medication. And so in our patients who we do have adherence challenges with, if we're able to get that information, we often do obtain it, but it is not required. What you should do is 12 weeks post-treatment, do a check for sustained viral response. And then you should also check their liver function tests at 12 weeks post-treatment to make sure that their liver enzymes have normalized after treatment if they were abnormal to begin with. So you're saying to me, ugh, this sounds complicated. I can't remember all the DDIs. You don't have to. You can just Google HCV Liverpool, and there's a website where you can put in the regimen that the person is on for HIV, and then put in the 2 different hepatitis C medications that you're likely to use, the Mavyret or the Epclusa, and see what the drug-drug interactions are. So here are the most common ones you have to look out for. We already talked about darunavir and ritonavir with Mavyret. But acid-reducing medications are difficult to administer with Sofvel. So the maximum PPI you can be on, I think, is 20 milligrams of omeprazole with Epclusa, and you have to space it by 4 hours. So that's difficult for patients and often would be a reason that you would try to go with Glipib if possible. Sorry, this slide should say atorvastatin and simvastatin are contraindicated with Mavyret. So that's another very common interaction in our patients, is that someone is on a statin, because everyone is on statins. And so you may have to change their statin to pravastatin at a lower dose while they're on treatment with Mavyret, if that's the choice of hepatitis C treatment. And the other one that comes up a lot for inpatients is rifamycin antimicrobials. So sometimes we get a call, oh, this patient's going to be in the hospital or on 4A for 6 or 8 weeks because of osteomyelitis, but they're on rifampin. And so and they have hepatitis C, you'd like to treat them while they're inpatient, but if they're on rifampin, that's not possible, as it's a contraindication for both Mavyret and Epclusa. So how do we know that minimal monitoring is safe? Well, there's a MinMon study, which I also presented last year, but I think is just super important and should be reviewed again. So in this study, there was no pretreatment genotyping. All of they used Epclusa, and all of that medicine was given at entry. There was no scheduled on-treatment clinic or labs, and just a phone call at 4 weeks and 22 weeks. And they also determined cirrhosis based purely on FIB4 score, no ultrasound. And of the patients enrolled in MinMon, 42% were living with HIV. And so there was some concern that SVR before the study was different in patients with HIV compared to those without, but this study showed very similar rates of sustained viral response in patients with HIV and without, leading to that guideline change in 2023, that patients with HIV and hepatitis C co-infections can be treated under the simplified treatment algorithm. So of the some updated data from that study was that of those 29 participants that had a positive hepatitis C RNA at or after the SVR visit, many of those were actually found to be reinfections. So they weren't failure. When they genotyped the hepatitis C virus from baseline and then at quote unquote failure, they found that several of those infections were actually reinfections. And risk factors for reinfection were HIV, men who have sex with having sex with men, and the majority of them were actually from the Thailand site. So maybe there was a preponderance of these behaviors at that site. And interestingly, they saw no difference in sustained viral response between those with a baseline resistance-associated substitution or mutation in the genome and those without. And we'll talk about that in more detail in a minute. And the second question that everyone always has is, is perfect adherence necessary to be cured? And the answer is no. And if you treat a lot of patients for hepatitis C, you will see this. You'll know that someone stopped taking their medication early or had a large gap and then were able to finish their medication and still achieve SVR, even if you were worried that they might not. And so there was a nationwide RCT that looked at this, randomizing 755 people who use injection drugs living with hepatitis C, and they actually use blister packs to measure day-to-day adherence. And they found that, if you manage to take over 50% of your medications, it's associated with quite high SVR rates, over like 80%. And if you take less than 50% of your meds, then greater adherence within that range is associated with SVR, as you might expect. Just completely stopping your medication early on and very long treatment interruptions are what's associated with failing to achieve SVR. I'm so sorry about this text thing that's happening. So case number 2. Miss B has a history of HIV well controlled on Simtuza. So just note another person who is on Simtuza. She is known to have a hepatitis C with genotype 3 because she was diagnosed a long time ago, and you have that data already. She's never been treated, and now she's reengaging in care. She feels like her life is more stable. She has stable housing, and she's really interested in being cured. And you also know that she has an ultrasound with documented cirrhosis, but no hepatocellular carcinoma. You talk to her and you calculate a Child-Pugh score. It's class A. She's compensated. She has compensated cirrhosis. She doesn't have active hepatitis B, and her pregnancy test is negative. So this is a hard question. So resistance associated substitution testing for Y93H in genotype 3 patients should be performed when either using Mavorite for treatment, regardless of cirrhosis, or Mavorite with compensated cirrhosis, using Sofvel for treatment, regardless of cirrhosis, or in patients with compensated cirrhosis, or actually you just have to give ribavirin to everyone who has genotype 3, along with the either Mavorite or Epclusa with compensated cirrhosis. I'm going to wait a little bit of time for this one. One hint is that this person has a contraindication to being on Mavorite. Wow, look at that. All right, great. Everyone knows the answer, or most people know the answer. So D, the answer is D, using Epclusa or Sofvel for treatment in patients with compensated cirrhosis. So yeah, this patient is on Simtuza. So naturally you would say, oh, she has a interaction with Mavorite. I'm going to use Epclusa. Oh, wait, she has genotype 3. I should actually assess for whether or not she has this resistance mutation that is associated with lower SVR rates in patients who are put on Sofvel. And just so that you know, we recently had this come up in clinic, and it was difficult to understand how to place the order. It's a miscellaneous lab order if you want to place this. And you have to flag in there that and specify that you want genotype 3 resistance testing. Otherwise, it might get routed to the wrong lab. So I think the question of when to obtain a genotype is somewhat confusing to people, because for the vast majority of patients, you don't need a genotype to get them started on therapy. The guidelines say that if someone has compensated cirrhosis and you are considering using Sofvel or Epclusa, that you should obtain a genotype because of this. In genotype 3 patients, 10 to 20% of patients have this Y93H mutation, and it can be associated, has been associated in prior studies with lower SVR rates. However, studies like MinMon, right, where they did no genotyping and they put everyone on Sofvel, show that you actually achieve quite high SVR rates, like even without doing any genotyping. So how do you reconcile those two things, I think is the question. And as I was saying earlier, more and more of our hepatitis C treatment is really reaching that like last mile of patients. And so I think what we should do is, if this is a patient you're seeing regularly in clinic and you know they have compensated cirrhosis, you should get a genotype, because you're going to see that patient regularly and it can inform your choice of therapy. But if this is someone who is having difficulty accessing care, I don't think there is necessary to obtain a genotype or should prevent them from starting therapy before you have that information. You can send it and start them on therapy. And then later on, if they fail, then you have that information. But the truth is that even some patients who have this mutation do well. So in MinMon, I think there were 9 people who had Y93H and only 1 person failed. So that's, again, telling you that overall, getting a genotype should not prevent you from putting people on Epclusa, even if they have compensated cirrhosis. That's my personal opinion. The guidelines would say to get a genotype. Oh, sorry. All right, so you get that testing. Well, it's all gravy. They don't have that mutation, and you can achieve cure quite easily. Which of the following is true? That now that you've got undetectable RNA in the blood, unfortunately, Hep C is still in the liver, but it could reactivate. B, Hep C antibody will protect them from future infection. C, Hep C cure is associated with reduction in stroke, heart attack, and kidney disease. Or D, hepatitis C cure will reduce the risk of hepatocellular carcinoma, but won't impact cirrhosis or fibrosis already present. I think the only tricky part here is probably between C and D. Right. So I think this crowd knows that once you've cured someone's hepatitis C, it's cured and it cannot reactivate. And we all know that when we screen people for hepatitis C after they've been cured, we have to use hepatitis V viral load to screen them, and they are not protected from future infection. We've all seen reinfections, right? But hepatitis C cure does more than just prevent the progression of liver disease, right? It's actually associated with reduction in stroke, heart attack, kidney disease. For the patient, it's doing a world of great things. So really, really important to cure people as much as we can. And then for D, hepatitis C cure will reduce the risk of liver cancer, and even can impact fibrosis, and up to 50% of cirrhotics will have fibrosis regression. So that's another really exciting reason to treat people and cure people for hepatitis C. So if a person has either advanced fibrosis or cirrhosis, you should continue to screen them for hepatocellular carcinoma after SVR. And that means ultrasound every 6 months with or without AFP testing, which is a less sensitive diagnostic. Just a quick reminder about decompensated disease. So you can't give HCV protease inhibitors in patients with a history of decompensated disease. So the way to identify a hepatitis C protease inhibitor is to look for the Previr at the end of a medicine. So Mavorite has a PI, and so does our retreatment therapy of Vosevi. It is possible to treat people with decompensated cirrhosis, but it's often much more difficult and a longer course of therapy. And in those cases, we generally work with hepatology to do so. All right, so then Mr. J comes to your clinic. He has a history of HIV well controlled on Biktarvy. His risk factor is IDU, and he's been diagnosed with hepatitis C after re-engaging in care. He does not have cirrhosis by Fib4. Uh-oh. Oh, hey. All right, this is better. Yeah. Okay. 3 weeks. So 3 weeks into treatment, sorry, you started Mavorite, 8 weeks of Mavorite, because he wants the shortest course of therapy, as most patients do. 3 weeks into treatment, you call him to check in, and he's like, oh, I took the first 2 weeks, but my life's been really busy, and I missed the last 6 days. What do you do next? Do you A, get an ultrasound? Do you B, restart therapy and just continue for the originally planned 8-week duration? C, do you restart therapy and continue for 12 weeks? Or D, restart therapy, check an RNA, and extend therapy if he is viral load positive. Sorry for that last bit after D. Remind us how long he stopped for. Yeah, that is the key to the question. He took the first 2 weeks and he stopped for 6 days. Okay. This is a question that I don't think anyone should actually know off the top of their head. It's a way to talk about the algorithm that's been released. So if you got this wrong, I'm glad no one put A, but otherwise, because that would be a little silly. But otherwise, if you put B, C, or D, none of those are wildly incorrect answers. The answer is B, restart therapy and continue for the originally planned 8-week duration. So the key to this question is that they missed less than 7 days of therapy, right? So whether or not your interruption is before or after 28 days of therapy, if you miss less than 7 days, you can just restart the therapy and continue for the originally planned duration. And then after that, it gets a little bit more complicated. If you miss more than 7 days, whether that interruption happens before receiving 28 days or after, and if you miss more than 21 consecutive days after receiving 28 days, then you should just stop treatment, assess for SVR 12, and then if SVR is not achieved, you retreat. So I think prior to these guidelines, this was sort of the question we would get the most from primary care doctors treating hepatitis C, right? Because treatment interruptions are quite common and difficult to manage. and there was no like written down guidelines about what to do. Now there are. So if you just Google HCV guidelines 2023, this algorithm will come up and it can help guide what you should do for your particular patient's situation. So I find this to be really, really helpful guidance. All right. Case number 4. There's a 35-year-old man with a history of prior genotype 1A infection, but you have documented SVR after he took Mavyret, and he recently relapsed with IV drug use and is now coming into re-engaging care and start BUP. His last LFTs 3 months ago were normal, and at that time you actually had a viral load 3 months ago that was negative as well. And now you have abnormal liver enzymes and rarely positive RNA. What do you recommend for this patient with acute hepatitis C? Treat now. I like your responses. So technically you could wait 1 month and treat if they don't naturally clear, but the guidelines are to treat now. And why is that? Because first of all, you have that patient in front of you right then, right? And you can get them started on treatment. But secondly, and almost as importantly, right, is that it reduces forward transmission. You know that this person is using IV drugs and that they are a risk for transmission to other people and other new cases of hepatitis C. So highly, highly recommend immediate treatment. If for some reason the patient wants to wait, you could wait 1 month and recheck their RNA. But again, I do not recommend that. I would just recommend treating as soon as possible. One thing to remember, of course, about retreatment, I mentioned this earlier, is that if they've been cured and are reinfected, it's okay to retreat with standard regimens. If a patient fails to achieve SVR or has a treatment interruption that you don't know about, and you're not sure about adherence versus whether they failed taking the whole amount of drugs, then you're typically going to retreat them with Vosevi. And it's a 12-week course. And if this happens to your patient, the guidelines are quite helpful in knowing what to do. So I just want to give Grace enough time to talk about all of her interesting stuff about the point of care, test and treat that we can do now. So my take-home messages are that we have really safe and effective treatment for every genotype and pretty much every person. The hardest patients to treat are those with decompensated cirrhosis, and in general, that's going to go to a specialist anyway. You really can do minimal monitoring, minimal pre-treatment assessment, and they're safe and effective in curing hepatitis C in people living with HIV and people who use injection drugs. Reinfections are really common in people with risk factors like HIV, IDU, and MSM. Please screen your patients often. And then, if they are reinfected and you've documented prior clearance, it's quite easy to treat them according to the simplified guidelines. Adherence issues are common, but they can be managed. Please remember to try to refer your patients to navigation services if you can. And just remember that SVR can be achieved without perfect adherence. And I'm going to give it up to Grace.
Thank you. Okay. Always fun to see what this computer will do with PowerPoint slides. So thank you, Jessica, for giving us a great overview on screening and treatment for hepatitis C. As she discussed, it's easier and simpler than ever. But there are still gaps in hepatitis C screening and treatment and cure in our country, as we talked about right at the beginning. So how are we doing in San Francisco? Well, among people with HIV, we're actually doing quite well in curing people's hepatitis C. So this is from a recent analysis that we did with the San Francisco Department of Public Health, and we found an over 85% clearance or cure rate among people with HIV and hepatitis C viremia between 2021 and 2023. So we're really doing a great job in this population, working towards elimination, but there is still this untreated group, and we're kind of really at this last mile of microelimination within our population and in people without HIV, which I'll get into the next slide. So who are these people? It's a diverse group, but we do know that according to recent NHBS data, people with HIV who inject drugs are the population with the lowest cure rates despite having high rates of infection. And so this is a population that I think is really important to target. And then looking at the general population in San Francisco, people without HIV, we're not doing as well. We see some key care gaps, both in those patients that get RNA testing who have a positive antibody. There are some patients that are getting lost before that RNA test is getting checked. And then more distressingly, we're seeing that under 40% of those who have documented viremia have documented cure. So there are really ongoing opportunities to improve our screening, our treatment, and cure documentation, and to really reach patients that are living with hepatitis C. So how can we address this? How can we address this last mile and reach these people that aren't being reached? One way that I would argue is learning, taking some of the lessons learned from HIV and implementing test and treat strategy for hepatitis C. Now that we know that treatment is easier than ever, this is something that we really can accomplish, but it kind of needs the right tools. So we know that rapid treatment initiation from work that was really pioneered here, that rapid treatment initiation for HIV helps to improve virologic suppression, increases care engagement, and it reduces forward transmission. We've seen this work in small pilot studies for hepatitis C, where this immediate, or very rapid treatment initiation can really help with care engagement and cure. But it does require access to immediate results and access to medications and care linkage. And so developing all of those tools and putting them all in the same place is really important to make this work. So the first step in implementing a rapid treatment initiation or a test and treat strategy for hepatitis C starts with point of care testing. In 2024, the FDA approved the first point of care hepatitis C RNA test, which provides qualitative hepatitis C RNA results within 1 hour using a finger prick test. And this is kind of the first step in allowing for immediate diagnosis and linking to care right away before patients might get lost to follow-up. And the existence of this technology, I think, has raised some really important questions of whether for certain populations we might be ready to move to a one-step screening strategy for hepatitis C instead of starting with antibody and then getting an RNA where patients might get lost to follow up in that time. For some patients, might we just start with viral first testing? This on the right here is from a paper that was modeling cost effectiveness and treatment outcomes if we were to implement different types of screening strategies for hepatitis C in the United States. The first two interventions that they were looking at focused on core antigen testing, which is not a test that's available in the United States, but highlighting intervention 3, which is using point of care RNA testing as kind of the first step to screen folks for hepatitis C. We can see that it's more expensive. That would be, if we were to implement that for everybody, that would be a more expensive strategy. However, it would improve health outcomes. The modeling suggested that this would improve number of diagnoses, number of people that were treated, and really importantly, decrease fourfold hepatitis C related deaths. So this type of testing strategy, I don't think is for everyone. I think if you have a patient who's coming into care regularly, they get their labs checked regularly, they're able to come back in for that follow-up test. They don't need to have a point of care test. They don't necessarily need to start with viral first testing if they're not known antibody positive. But for patients that are in high prevalence settings that may not be routinely engaged in care, starting with a one-step testing strategy may help to diagnose more infections and really engage patients at the point of diagnosis. So let's talk about how that point of care one-step testing might be applied in the real world by going through a case. So this is a 32-year-old woman with HIV. She's on Big TAF FTC. She also has opiate use disorder and reports injecting drugs. And she also has housing instability. She's missed several PCP appointments. She cites her homelessness as her primary barrier to kind of making routine clinic appointments. But she has been adherent to her ART. Her last viral load was undetectable 4 months ago. So when she comes into clinic, she mentions that her partner was recently diagnosed with hepatitis C, and she's wondering if she could have it too. She tested negative for hep C about 2 years ago. She also notes that she's a hard stick and she doesn't really like getting her blood drawn. She will do it though if it's absolutely necessary. So you're lucky because this patient is in the lobby where we now have a point of care hepatitis C RNA test. And so we're going to offer her a point of care finger stick test. So for our first question, if that point of care test comes back positive, what results do we need back before we can start her on treatment, before we can get her drugs in hand? Do we need pregnancy test, AST platelets? Do we need a hep C viral load? Do we need a hep B surface antigen? Which combination? I'll give you a couple minutes to answer, or a few seconds to answer. Okay. Okay, interesting split, a big split, which is great because this is a really complicated question. And the answer may surprise you. So the answer here is actually D. And I'll remind you, the question here is which results do we need back, not which tests do we need to run. So this was very intriguing to me. So I'm going to walk through kind of what the guidelines say. So in this year, IDSA and AASLD released updated guidance on hepatitis C, and they included an algorithm for test and treat using point of care hepatitis C RNA testing. So I'm going to walk through kind of what that algorithm says. And this is very similar to the routine, guidance for simplified treatment, but kind of seeing how we can do this, more quickly. So the first step, it starts with point of care hepatitis C viral load testing via finger stick. It's also recommended to get other point of care testing as indicated for the patient. So for our patient, we know that she has HIV. She does not need a point of care HIV test, but she's of childbearing potential. So we should get a pregnancy test at the point of care. And I apologize for the formatting here, but if that point of care test comes back positive, next you want to ask, is there any known contraindication to simplified treatment? And these are the same questions that you would ask for a patient that's getting standard phlebotomy testing. Is there a reason why you can't go through the simplified treatment algorithm? So same things, is there known hepatitis B? Is there known decompensated cirrhosis? Do you know that this patient has drug-drug interactions that are going to require some sort of medication adjustment? If the answer to any of those questions is yes, then that patient is probably not a good candidate for same-day treatment initiation. You may require kind of consultation with a specialist depending on what's going on with the patient. However, if the answer to that question is no, you're going to obtain labs and you could start treatment that very day before the labs have actually resulted. As a reminder, the labs that we need for pre-treatment evaluation for hepatitis C are pretty minimal. We do want to get AST, ALT platelets, a recent creatinine to make sure that there's no advanced CKD, advanced fibrosis or cirrhosis. But these labs don't need to be from that day. If the patient has recent labs that were checked, you can use those for that fibrosis assessment. And this treatment algorithm is really meant to target a younger population that is less likely to have advanced cirrhosis from their hepatitis C. And so the odds of that happening, I think, are quite low. You do want to assess for hepatitis B with a hepatitis B surface antigen. Of course, if this patient last month had hepatitis B labs and they had vaccine-mediated immunity, you don't necessarily need to check another surface antigen that day. But I would recommend getting a hepatitis B surface antigen if they don't have one that's quite recent. I would also recommend obtaining a quantitative hepatitis C RNA and a genotype for patients. Strictly per the test and treat algorithm from IDSA and AASLD, these are not actually required and should not limit your ability to start treatment. You should still feel empowered to start treatment if this patient has had some recent labs and doesn't have these. I think it's useful information to have in case there's a treatment interruption so that you can monitor, or there's any concern for reinfection. These are data points that you probably would have wished that you had if that were to happen. However, technically, this is not required by their guidelines. And then the treatment is the same. So 8 weeks of Gleepib or Sofpel for 12 weeks are generally the recommended, pan-genotypic regimens. And that can be by patient preference and assessing the drug-drug interactions. Now, if there is an unexpected lab result, such as a positive hepatitis B surface antigen, the patient may need consultation with a specialist. They may need to come back into clinic. So it's important that the patient is reachable and that they're counseled before starting, to know that there is a low, but there is a risk of that you could have hepatitis B and that this could affect your management. And so you may need to come back in. However, the rates of hepatitis B surface antigen positivity in the United States are not particularly high. And so when weighing kind of risk benefit of, I have this patient right here and I can start them on treatment, you should still feel empowered to start. I also will note that a point of care hepatitis B surface antigen test is in development. And so this would simplify this even further if and when that becomes available. So to summarize kind of hepatitis C point of care, we're making great strides in San Francisco for treating and curing a lot of hepatitis C, but there is still a last mile of patients living with hep C that we need to reach. And point of care testing may be a tool to accelerate treatment, including implementing test and treat strategies and allowing for same-day diagnosis and treatment initiation to engage more patients at the point of care. You don't need to have lab results back at the time of treatment for all patients, and just make sure that patients are reachable. Okay, now I'm going to change lanes a little bit and just talk briefly about hepatitis B, our other favorite viral hepatitis, with just a couple cases. All right, so this next case, we have a 36-year-old man. He has HIV. He's undetectable on ART. He reports that he's been vaccinated against hepatitis B before, doesn't know exactly how many doses he got, but you check hepatitis B serologies and it looks like he is hepatitis B susceptible with a negative surface antibody, negative core antibody, and negative surface antigen. So he did not respond to the prior vaccines that he received. So we're going to offer him a hepatitis B vaccine. Which one would you choose? The Engerix or Hep B alum vaccine, Twinrix, the combined Hep A, Hep B vaccine, Heplisav B or the CpG conjugated vaccine, or does it not matter? Any of them are fine. Okay. Excellent. All of you did great. This is the correct answer. So getting into the data of why we prefer this vaccine over all the others for Hep B. This comes from the A5379 or Beehive study, which investigated the use of the Hep B CpG conjugated vaccine compared to the standard hepatitis B alum vaccine in people with HIV. There were two groups in the study. Group A were patients that had been previously vaccinated against hepatitis B, but had had vaccine non-response, so like the patient in our case. And in this group, they were randomized into 3 arms. The first arm received 2 doses of the CpG vaccine. The second arm received 3 doses of the CpG vaccine, and the third arm received 3 doses of the Hep B alum vaccine. Group B were patients with HIV who were vaccine naive, had never received a hepatitis B vaccine, and that was a single arm. All patients in that arm received 3 doses of the Hep B CpG vaccine. Seroprotection was checked at various time points, and this was defined as having a hepatitis B surface antibody level greater than or equal to 10, counted as having seroprotection. And then patients were followed over time. The results of this, the end of study results were recently published. And so going through their primary endpoint, the seroprotection at week 72, can see in this graph here, the gray circles are 3 doses of the CpG vaccine, and nearly 100% of patients had seroprotection all the way out to 72 weeks. The orange is the patients that received 2 doses of CpG vaccine. They also did quite well in terms of seroprotection, with about 85% having seroprotection at 72 weeks, a little bit less than the 3-dose arm. And then both CpG arms outperformed the Hep B alum vaccine, where under 60% of patients had seroprotection out to the end of study. So this study demonstrated that in people with HIV, primarily focused on vaccine non-responders, but also vaccine naive patients as well, that the CpG vaccine was superior to Hep B alum, and that 3 doses was better than 2. And importantly, this was durable protection over time, which is awesome. And notably, it's not really shown in this graph here, but they checked quantitative levels of surface antibody, and in a very large proportion of the patients in the 3-dose arm had surface antibody titers greater than 1,000, which we think confers even more durable protection. Okay, so that's the vaccine. Now we're going to move into a real case. This is a 46-year-old man with HIV, opiate use disorder. He was diagnosed with this HIV in 2002 and has been viremic for most of that time. He reports that he has a really difficult time adhering to oral medications. His current regimen is Bictaf-FTC, but he says he has not been taking it. And he expresses some interest in long-acting injectable therapy. Some labs here, he's viremic, being off ART to 800,000. His CD4 count has been decreasing over the last several years, and it's now down to 57 or 5%. For his hepatitis B labs, he's surface antibody positive and core antibody positive. His surface antigen is negative. And then CRAG was negative, normal renal and kidney function, normal CBC, no fibrosis or cirrhosis. It's also not on the slides here, but I'll mention he's had numerous genotypes, has no drug resistance, known resistance-associated mutations. So we know from updated guidance and from a lot of the work done in this clinic that for patients that have adherence challenges to oral ART, that long-acting injectables can be a really wonderful option. So we're thinking about this for this patient. With regard to his hepatitis B, is that going to affect your management at all? Reminder, his surface antibody was positive, his core antibody was positive, and his surface antigen was negative. Ready to vote. Okay, great. So a little bit of a split, but most people choosing to start injectable cabotegravir rilpivirine. And I agree, this is a patient who, based on his adherence challenges, I think would do great with, or that injectables should be offered to him. His CD4 count is now less than 100. It's really time for us to help him with controlling his HIV. And his surface antibody is positive, so he's not really indicated to get a hepatitis B vaccine. There is a risk of reactivation, which we are going to get into, but looking at the data that is in front of us, I think it's very reasonable to just start treatment, start Cabril. So that's what happened. He got started and responded beautifully. His viral load quickly became undetectable. His CD4 count came up to over 200 and was doing really, really well. About 2 years later, after starting long-acting injectables, he had some labs checked and he had some new LFT abnormalities. This was repeated on a couple of subsequent CMPs. And so he gets further worked up, and now he is surface antigen positive and has hepatitis B viremia, so had reactivation of his hepatitis B. So we know that incident and reactivated hepatitis B has been reported for patients on cabotegravir rilpivirine and other tenofovir sparing and hepatitis B inactive ART regimens. These have been rare. A lot of these have been reported in the form of case reports with really a wide range of kind of clinical outcomes. Some reports have just had patients had asymptomatic low-level hepatitis B viremia with normal LFTs. Other patients have had acute liver injury and even acute liver failure. So a very rare but potentially very serious outcome. So how do we understand who is at risk and what's happening here? Well, when it comes to reactivation, the largest study that looking at this came from the Veterans Affairs cohort study. They looked at about 6,000 patients with HIV who were core antibody positive and started on, but surface antigen negative, who were started on hepatitis B inactive ART. And they found 89 cases of reactivation, 39 of which were confirmed with multiple positive DNA checks, with a median time to reactivation of about 300 days. They found that the highest rates of reactivation were among people who had never mounted a surface antibody response and or had ever had a reported positive surface antigen. None of them were surface antigen positive at the time of switch, but at some point in time had a positive surface antigen. However, I will note that while extremely uncommon, they did find cases of reactivation among people with all types of baseline serologies. And so this, again, rare, but can happen regardless of hepatitis B serologies like we saw in this patient. The other thing I'll just remind everyone of is that when starting a hepatitis B inactive regimen, such as long-acting injectables, screening for hepatitis B immunity and appropriately vaccinating people, this is an incredible opportunity to incorporate this into your practice. I'll just note that there have been some reported cases of incident hepatitis B reported in trials. This is an example here from the Impala study, which is a phase 3B study looking at cabotegravir rilpivirine compared to dolutegravir with 2 NRTIs for patients with adherence challenges in 7 sites in Kenya, South Africa, and Uganda. I'll note that this is a region of the world that has a higher incidence of hepatitis B, higher prevalence of hepatitis B compared to the United States. So patients in this study were excluded if they had active hepatitis B infection with a positive surface antigen, and they also excluded folks who had isolated core antibody positivity. However, they did allow patients into the study if they did not have prior hepatitis B vaccination or Hep B or vaccine-mediated immunity. A sub-analysis looking at the hepatitis B outcomes for this study were presented at IAS this year. And looking at this, notably, really a minority of patients enrolled in the study had vaccine-mediated immunity, and at least at the time that this study opened, Hep B vaccination was not a part of the protocol. And we saw that there were no cases out to 48 weeks, no cases of hepatitis B reactivation in patients who had core antibody positivity, but there was one case of incident hepatitis B infection in a patient who had no vaccine-mediated immunity. The patient developed LFT abnormalities. Further investigation revealed that the patient had acquired hepatitis B. So this is just, and this I think has helped to further discussions about how we can incorporate hepatitis B vaccination into our clinical trials of Hep B inactive ART. And I would encourage everyone to also incorporate that into their practice, that when making that switch, just making sure that we're preventing hepatitis B infections when possible. So some takeaways here, we know that the hepatitis B CpG conjugated vaccine is superior to our older hepatitis B vaccines in people with HIV. I would encourage 3 doses of that vaccine if possible, but 2 doses is also quite good. And then hepatitis B reactivation and new infection can happen on hepatitis B sparing ART regimens. Likely the highest risk is for those who have had a positive surface antigen in the past and who don't have a positive surface antibody. But as we saw in our case, this can happen with any serology. So vaccinating patients who are not immune is an important part of our global treatment of these patients. But the other thing I think I want to impart is not that, this is, again, a very rare phenomenon. So we don't need to necessarily be proactively monitoring and worrying that all of our patients on injectables are going to have reactivated hepatitis B. The point is just to make sure that it's something that you are aware of. So monitoring LFTs with just routine labs and having a low threshold to do further workup, and making sure that you're counseling patients appropriately when making that ART switch. And I think that's it that I have.
That was fantastic. Thank you. We'll take any audience questions that we have.
Thank you both. That was so phenomenal, both of you. I have a question for Jessica about candidacy for the simplified treatment algorithm. Something that sometimes confuses me, I think, as I approach Hep C from an HIV-centric lens is use of the word failure. And I feel like sometimes it's used to describe people who, say, just had a week and then didn't achieve cure. But that is called failure as compared to, say, someone who completed treatment like all 8 weeks and then didn't achieve cure. And so I was just hoping you could define what failure means in that list.
Yeah. Yeah, I think what failure means in that list is that they took like a substantial, and how to define that is like definitely. I think you can sort of look at those treatment interruption guidelines, right, to get a sense of like what is defined as failure. So, right, like if you took more than 28 days and then you skipped a whole bunch, like that person should be treated as like along the retreatment guidelines, because they actually got a lot of exposure to drug. But if someone just got 7 days and just completely stopped, like something happened in their life and they lost the meds, for example, and you know that, I don't think you necessarily have to retreat with Vosevi. You could just redo with the simplified treatment. Yeah, the treatment guidelines. So I think the tricky part is that it's difficult sometimes to know how much someone took, right? That's the hardest part, because reporting, it's hard to know, even when you take your own medicines, right? But if someone's very clear about what happened and they took a very little of the medication, then it's safe to retreat them with the standard medications. It's only after they've taken a substantial amount of the medication and or you're not sure how much they got, that it would be safer to go with Vosevi. Yeah.
I wanted to make a comment about that. First of all, what a great talk from both of you. It was just awesome. So great to see so much progress in hepatitis and an exciting spot. We usually use 4 weeks as the cutoff. And I will say, I disagree with the simplified treatment guidelines where they say prior hepatitis C. If you've been treated and cured, great. You've started de novo. Like, you should not have that held against you. And I think this was pointed out nicely by the presenter. So if it's gone, and you can be considered as restarting. And 2 just really exciting updates that I wanted to share. So Grace highlighted the surface antigen for Hep B. So this is available all over the world, just not in the United States. So finally, a government-funded study is going forward. We hope to be a site here, but it'll be a finger stick lateral flow assay that's like a pregnancy test. So you could test people right at the time and know. You got to work them up more if they're surface antigen positive, but that would really help here. So that is coming, and hopefully even in our clinic soon, as we're getting that validated. And I wanted to make one other comment just as an update here, which is just to remind folks, and I think, Jess, you mentioned people on the inpatient service. So just to remind you that if you have a patient on the inpatient service who is there for a week or more, or anticipated to be there for a week or more, you can treat them. And the residents have really taken this on. It's their house staff improvement project for this year, so that's terrific. And it doesn't have to go through ID. The pharmacists have been really terrific. If they're being consulted on for ID, ID should get involved, and we're going to be rolling out a lot more educational information about that. But just know people can be treated inpatient. There's some hoops we have to jump through, but we should definitely do it.
And I do think that messaging is getting out to the inpatient teams, because we were consulted recently on someone who had hepatitis C infection, but they were in the ICU with like very, very acute illness. And I was like, good point, good catch. I love the enthusiasm. Let's wait until some of these other issues are sorted out and we know how long they're going to be in the hospital.
Hi, very great talks from both of you. Thank you so much. This might be a question for both of you, but it's about Grace's first case. In that case, if she did come back Hep B antigen positive, assuming that she's HIV positive and possibly on a regimen that's covers for that, how might that affect the treatment that you had already started, if you had already started when that came back?
Great question. So yes, so you can still treat, you can and should still treat her hepatitis C. She would just need to also have her hepatitis B treatment. Of course, in this scenario, this patient is already on hepatitis B treatment, so she may be just kind of fine, but it's generally for kind of that unexpected Hep B positive result. You just need to also treat their hepatitis B because they're at higher risk of Hep B flare while they're on Hep C treatment. So it would be a discussion with the patient if they're willing to start therapy for their hepatitis B and getting that started. Also requiring some additional labs, like what their Hep B DNA level is.
Thank you both for fantastic talks. Any updates on a single shot long-acting therapy development for Hep C? Kind of where are we at in the pipeline for that? Maybe topic for another day.
I'm gonna throw that to Annie.
Very actively in development, and they think they have a good candidate. It probably will be 2 shots, not just 1. But this has been an issue of money and will. But there is a good candidate out there that people are trying to move forward. It's a great, and same, we could use that for
something for hepatitis B as well. And the initial products did not do well with that because it has to be lifetime treatment, but important areas.
Great. Let's go to Scott in the back, and then we have one question online.
These were great. Thanks. Question, your last case made me think about in the test and treat algorithm, there's no Hep B core antibody test. Used to be a thing that we did routine. I mean, we still do routinely for folks. Is there a reason for that? Like not check in to make sure that you have to monitor more? Is it not recommended anymore for some reason?
So generally, I would recommend if you're screening for Hep B, so all adults should be screened for Hep B, and I would recommend that they get screened with all 3 surface, core, and antigen testing. However, this is really kind of the purpose of the test and treat algorithm is, I think, really to focus on kind of, especially like a non-clinic setting. So like the delivery van or in a more low barrier setting where it's just like, what is the minimum information you need to be able to safely start this person on medication? And so getting a core is not really necessary in that case because you really only would change your management if their surface antigen were to be positive. However, I do recommend that all adults get screened with all 3. And so if you have a patient who's willing to get labs and they don't have the full set of serologies, I would check them. It just shouldn't, it shouldn't prevent you from starting treatment if you don't have that information.
Okay, great. And then insurance coverage and access to Hep C meds. This seems like a barrier to rapid start. Can you tell us more about that?
So yeah, so I think the infrastructure does not exist in most places to do like meds in hand, like starter packs for hepatitis C. I think to really implement it, we would need to have starter packs available so that you could give patients their first week of medication while you do the insurance authorization and get all of that settled so that they can then get the rest of their prescription through the pharmacy, much like we do for HIV rapid starts. And that's going to vary on setting where, when and if that's available. I think there still is benefit to being able to get all the information and like start that insurance auth or send that prescription same day, even if you can't have them take the first dose in front of you in clinic. But I do think that in certain settings, being able to like getting funding for starter packs would be really helpful. Hep C treatment is covered by almost all insurance. And so if patients are uninsured and just need to get insured, or they just need some sort of authorization to be done, if they have health insurance, they should be able to get hepatitis C meds covered. It's just a matter of making sure that all the I's have been dotted and T's have been crossed.
Okay, yes.
Sorry. Yeah, so they removed the prior authorization for Medi-Cal, which is a big deal. So you can get meds usually within a day. That's not the case with all insurance. And we just had a big win that's going to be coming out soon, which is that Medi-Cal has authorized dispensing of a full course of therapy. Nice. So that will be huge. So people don't have to keep coming back we've seen so many people come back and they couldn't get the 2nd or 3rd month because life got in the way. So you're right. We'd like to be able to give them the same day, but I think we're getting very close, at least with one day if you're working closely with your pharmacy. So we're getting there. And then you can just dispense the full course starting October 1st. So that's great news.
That's huge to give the whole 8 weeks or 12 weeks. Okay, we're going to stop there. Thank you very much. That was so fantastic, so relevant to our clinical work. Thank you both so much.